single segment of the liver needs to be resected for pathology. Its artery can be clamped with minimal blood loss. Surgeon can first perform a Pringle maneuver when the artery to that segment is clamped. The part of the liver supplied by the artery becomes blanched. Surgeon can see the outline of the segment and carry out a dissection with minimum blood loss.
Very good, sir. So this is basically, it has got an independent artery, arterial supply, portal vein supply, and independent drainage of the
artery segment is clamped. The part of the liver supplied by the artery becomes blanched. Surgeon can see the outline of the segment and carry out a
Okay. Can you hear now?
Other classification is bismuth classification.
Okay.
Under bismuth, there are three portal veins, left, middle, and right. They divide the liver into 4 parts.
Sure. Okay. So if you give this much information, it will be sufficient for this one. Another is a morphological, what we usually divide with falciform ligament as right and left, caudate and quadrate. So to complete the answer, but they'll expect this functional coinoid classification because that will be important. So the next question following could be what detail about microscopic anatomy of liver?
Yes, sir. Structurally, the unit of liver is lobule, but functionally it's an acid.
Yeah, they will expect this differentiation, sir. If you are able to tell this differentiation, you
lobules. Structurally, lobules are like 2 prisms joining each other on its base. On a 2D, if we draw the diagram, it looks like a hexagon with this vein in the center, and on the 6 sides, the portal triads. Oxygenated blood arrives through the at the triad from the hepatic artery, and it into channels called sinusoids and drain into the central vein. Bile secreted drains into the biliary radicals, which ultimately drain into the left and right hepatic veins. Left-right hepatic duct, and then they join to form
common biliary duct.
The common hepatic duct, and then joined by cystic duct and continues as common bile duct. The can I try to draw the structure? If that can.
At least a lobule and acinus you can draw, sir. A lobule and the acinus.
Okay.
That's at the same time when you talk about
now I tried this. I'm trying to use a wide board.
Okay, so you can practice that. So you can do one thing when you start talking itself. You can open the whiteboard on the side by side, and you can keep drawing and then explain. That will save your time.
Yes, sir. Yes, sir. But next time I will.
Yeah. So for you to practice,
it's the first.
Because for an exam, you have only 5 to 6, 12.5 minutes for one examiner, so that you can take as much as questions possible. Yes.
This is the gross structure, and there would be other adjoining structures. So,
can you tell where will be the asinus, sir? Starting from where will be the asinus?
Fine, sir. Asinus would be an elliptical area.
Yes.
Here.
Okay.
This would be the asinus. The hepatocytes around this are divided into 3 zones. This is zone 1, zone 2, and zone 3. 1, 2, and
can you elaborate about the zone 1, zone 2, zone 3?
Yes, sir. Zone 1 gets the highest oxygen content. They are best supplied with oxygen. They carry out functions which require more of energy and oxygen, like gluconeogenesis, cholesterol synthesis. Zone 3 gets the least blood supply. They carry out less energy intensive functions like drug metabolism and glycolysis. Zone 2 is a compromise. The structure of the functional, the structure of
Yes, sir. Go ahead.
This is the canal. This is a sinusoid, and this is hepatic artery, hepatic vein, and this is biliary canaliculi. So blood flow from these two flows in and mixes here, drains into the central vein.
Yeah.
And hepatocytes secrete bile into the biliary radicals, which flows here.
So it's opposite direction, right?
Yeah, opposite direction.
Okay.
Stellate cells are found here, and Kupffer cells are found here.
Okay.
Into the sinusoid.
So I was about to ask the next question. What are the types of cells? So you elaborated in brief already. So
yes, sir. Hepatocytes, Kupffer cells, stellate cells.
Okay. So ito cells are those which is very activated during the cirrhosis, and it produces a lot of fibrosis. Kupffer cells are immunological cells. So some function, one or two functions of each cell is important.
Yes.
So by and large,
and this space is space of Dissay. Space between the hepatocyte and the basement membrane and the endothelial cells. One quality of the endothelial cells is they lack a basement membrane and they allow passage of large molecules like albumin.
Okay. Good, sir. This is means by and large anatomical knowledge is enough for us to pass the EDAIC. I think you are comprehensively covered everything, both macroscopic and microscopic, and the related functions you have told. So now, by and large, can you tell what is the functions of liver?
So liver functions are metabolic, secretion of bile, excretory functions, vascular functions, immunological functions, and secretion of lymph production. Metabolic functions are metabolism of carbohydrates, which involves conversion of galactose and fructose into glucose, and after that it follows a common pathway. Glycogenesis and glycogenolysis, gluconeogenesis using either amino acids like alanine or from glycerol. Other functions are conversion of carbohydrates into triglycerides, and this function is performed in liver and in the adipose tissue. They can be stored. Liver is very important in maintaining glucose level in the blood. In the situation when liver function is impaired, there's a serious risk of hypoglycemia. Proteins, it converts synthesis of non-essential amino acids and lipoproteins.
See, actually, you don't need to give so much in detail, but by and large, you can divide it into mainly metabolic, then exocrine, endocrine. Then next is immunological, as you said, and synthetic function and drug excretion. This is the first 6 function major. Metabolic, you can, as you said, all the carbohydrate, fat, and protein metabolism, including gluconeogenesis, glycolysis, glycogenolysis, protein synthesis, beta oxidation, urea synthesis, everything comes under this category. Exocrine, mainly bile salts and bile pigments. Okay, so this helps in fat metabolism and absorbing vitamin A, D, E, and K. And then endocrine, it activates the vitamin D mainly.
Yes.
It plays a central role in renin-angiotensin system. Okay, and detox and inactivation of aldosterone. It happens here. This is mainly one or two examples for each heading.
Inactivation of many hormones also.
Hormones also, yeah, estrogen, everything. And then we can go to immunological. It is the first what is it, graveyard of
Kupffer
immunology.
cells.
Yeah, Kupffer cells is the first gate of immunology.
Complement
Yeah.
system.
Yeah, it activates
CRP.
everything. Yeah. So you can immunology, you can
Production of amyloid.
one or two functions of immunology. Then synthetic, all the prothrombin, procoagulants.
All
like,
the clotting factors,
clotting
albumin.
factors. Yeah. And even the anti coagulants like protein C, S, and antithrombin.
Yes, CS and Z.
Yes. And the drug excretion, drug metabolism. So if you first you try to enumerate all the functions as you did, 1, 2, 3, 4, 5, 6. Then they'll know, by and large, the thing. Then you can detail each function as you go on. Sometimes, usually, this is a long list. So they to me, they cut short. Means it was in a basic science. They cut short after I did 2 or 3. Then they said it's enough. We'll go to the next. Means once they know that you have in-depth knowledge, they go to the next question. So they want to give you more chances. Okay. Thank you, sir. You have completely finished the anatomy question comprehensively.
You,
so anybody wants to take on physiology?
May I?
Yeah, yes, Dr. Deepak. Yeah, okay. So now finishing the anatomy, now can you just describe the blood supply to liver?
So the blood supply to the liver, it has got a dual blood supply. Through the hepatic artery, which is a branch of celiac artery, and the portal vein, which forms to the confluence of the superior mesenteric and the splenic vein. Now the blood supply, the saturation of the artery, saturation of hepatic artery is, as the arterial saturation, 98%, and the saturation of portal vein is like 70 to 85% according to the fed or fasting status. So the oxygen supply is through hepatic, through portal vein, it is around 60 to 70%, and through hepatic artery it is 30 to 40%. And the oxygen supply is almost around equal, 45 to 50, and 55 to somewhere 50 to 55%.
Okay. So what is the total blood supply, in the sense how much blood is stored or passes through the liver in a minute?
So liver gets around 25% of the total cardiac output, which is around 1.5 liters.
You start your answer with this because they will like to hear this. Okay, once you start this, then you complete your answer how you did. Okay, next. How is blood supply regulated?
So the blood supply regulation has got two factors: the intrinsic factor and the extrinsic factor. The hepatic artery is regulated through both the intrinsic and the extrinsic factor, and the portal vein supply is regulated only through the intrinsic factor. So first mechanism is the myogenic autoregulation. It occurs in hepatic artery. So as the mean arterial pressure goes down, the hepatic arterial resistance also decreases, so the arterial blood supply increases. This autoregulation is maintained till 60 millimeters of mercury mean arterial pressure. Then after this myogenic autoregulation, it has hepatic arterial buffer response system, which says if there is decrease in the portal vein supply, hepatic artery increases its supply, and vice versa. This mechanism occurs through the adenosine, release of adenosine, which causes hepatic artery to vasodilate. This and then some mechanism, the sympathetic supply, which like portal vein has got the only alpha receptors, and the hepatic artery has got alpha and beta receptors both. And through this sympathetic mechanism, it vasoconstricts, and thus it regulates the blood supply.
Okay, good. So if you can elaborate this much, I think one more thing which you can add in the extrinsic factors is the role of respiration. Whether it's a spontaneous,
role of respiration.
Yeah, the spontaneously breathing. Yeah, go ahead.
Yeah. So in spontaneously breathing, when the patient takes inspiration, there is the blood is like venous return is increased, and it causes increase in the hepatic artery blood flow. As compared when the patient is under positive pressure ventilation, when we give inspiration, the positive the venous return is decreased, and it causes decrease in the hepatic artery blood supply.
Yeah, that's enough. So you have to tell both in the spontaneous and in the positive pressure ventilation what happens. The broad ideas also is okay. So now, can you enumerate what are the factors which reduces blood supply during surgery and anesthesia? So anesthetic factors, you can grossly divide it into anesthetic factors and surgical factors.
Yeah. So the anesthetic factors includes the agents which we use.
Very good.
All the agents like volatile agents, volatile agents reduces the blood supply. Then, as we said, the positive pressure ventilation, it reduces the blood supply. And
vasopressors. Just now you told vasopressors alpha.
Yeah, vasopressors. The use of vasopressors, they vasoconstrict and they decrease the blood supply.
Okay. Any role of any hypotension due to regional anesthesia and general anesthesia?
Yes, sir. Yeah, hypotension due to regional anesthesia also decreases blood supply.
Okay.
So sorry, sir, I have to cut down. Sorry, sir, extremely sorry.
No problem.
Actually, I think there is some problem. I need to go, sir.
Go. Okay, you can proceed, please. Anybody want to take over?
Yeah, I can take over.
Yeah, please.
I can take over.
Dr. Minotti?
Yeah. So during hypotensive episodes and during regional anesthesia, liver behaves as a capacitance vessel. During hypotension, that much amount of blood can be pushed into the circulation. So that causes decrease in the blood flow to the liver.
Yeah.
Inhalation agents.
Inhalation agents
can reduce the blood supply. Surgical handling of the liver also reduces the blood supply. During periods of fasting, the blood supply is reduced.
And any role of carbon dioxide?
Carbon dioxide will cause an increase in the
increase in the carbon dioxide increases the blood flow. Decrease
will cause vasoconstriction.
So divide it into anesthetic and surgical causes and enumerate at least 2 or 3 in each heading. That should be sufficient. Okay, so that completes the almost the physiology and the anatomy of liver, which is commonly asked. And in this regard, they may ask about a word about halothane hepatitis because the drug. And can you tell about halothane hepatitis?
Halothane hepatitis is basically caused due to exposure of halothane. It is seen there is because of a genetically induced. There are 2 types of halothane hepatitis. Type 1, which is less fulminant, which after exposure causes increase in the transaminase to a certain levels. And there is type 2, which leads to severe increase in the transaminase levels. It causes a reactivity between the proteins, and then it forms antibodies. So that can cause fulminant hepatitis. So when the exposure, second time exposure occurs, patient can have fulminant hepatitis with the exposure to halothane. But it is seen only mainly with halothane, not with any, not the other volatile anesthetic agents.
And in case, which will be the best anesthetic agent, volatile anesthetic agent?
Sevoflurane and desflurane are considered to be better anesthetic agents as compared to halothane.
Why?
Because they do not form these
normally you said it metabolized very less in the
liver.
Well, very less in the liver, and it leads to less hypotension. Okay, so in comparison. Okay.
Especially if they are limited to 1 mAc.
1 mAc, yeah, up to 1 mAc, yes. Okay, so now about jaundice. Can you classify jaundice? This could be a table 3, clinical anesthesia viva. So jaundice, can you classify jaundice? Anybody?
Yes, sir.
Please, sir, go ahead, sir.
So jaundice can be classified as pre-hepatic, hepatic, or post-hepatic. Pre-hepatic is characterized by rise in unconjugated bilirubin, usually caused by resolving hematomas, hematoma reabsorption, or blood transfusions.
Hemolytic anemias.
Hemolytic anemias. Excessive bilirubin is produced, and normal liver working at normal capacity is still not able to conjugate all of it. So there is accumulation of unconjugated hemoglobin. So it's characterized by normal enzyme levels, a rise in stercobilinogen, urobilinogen, and and a normal conjugated bilirubin level.
Yeah, so it is mostly unconjugated bilirubin which raises with normal liver enzymes and absence in the urine, because bilirubin absence in the urine. Okay, now hepatic.
Hepatic can be infective, viral etiology,
okay,
drug-induced, autoimmune, and some other rare conditions like Wilson's disease or hemochromatosis.
Okay, infiltrative diseases, yes.
Post-hepatic is because of obstruction to the biliary outflow. Commonest cause is stones in the common bile duct or carcinoma head of pancreas. There may be some other conditions. And in the hepatic part, there are a few congenital syndromes also, like Gilbert and Krigler-Najar, and Downs and Rotor syndrome. Dubin-Johnson and Rotor syndrome.
Okay, good. So by and large, you should have a gross where unconjugated increases, where conjugated increases, and enzymes. They will ask about enzymes. So post-hepatic, the rise of GGT and alkaline phosphatase. Those should be mentioned. Very good. So next we'll go to the liver disease. So can you classify liver disease? How will you classify liver diseases?
This can be classified according to its onset, acute or chronic. Acute can again be classified into acute, hyperacute, or fulminant.
Very good.
If the interval between the onset of symptoms to development of jaundice is up to 1 week, it's acute. It's 2 to 5 weeks, it's hyperacute, and if it's more than 6 weeks, 6 to 26 weeks. And chronic liver disease is defined with a little less certainty, but commonly accepted. Persistently increased enzyme levels for 3 months or more.
Okay. So as you said, it is acute liver failure and chronic liver failure. Acute is hyperacute, acute and subacute. Hyperacute is 7 days. Onset of jaundice to the hepatic encephalopathy, 7 days. So it's hyperacute. Acute is 1 week to 1 month. 1 month to 3 months will be subacute. And you correctly pointed out that chronic liver disease is very vague, and it is more than 6 or 7 months of persistent increase in the liver enzymes or liver dysfunction. Okay, there is another entity called acute on chronic liver disease, where this is very small information only. So acute on chronic, where any patient who has chronic liver disease has got some acute decompensation. Okay, so these are the 3 types.
Surgical stress, sepsis, infection can cause any patient suffering from chronic can have an acute liver.
decompensation. Yes.
Or even drugs.
Use of liver hepatotoxic
Alcohol.
drugs. Yeah.
Alcohol, paracetamol.
Yes, can lead to acute and chronic. So classification, you should be very clear and make sure that this is a very pass-fail question, because for this question, this is a very basis one. The next is, can you elaborate extrahepatic manifestation of the liver disease? So somebody's asked,
Yes, sir.
can you please repeat the duration? Okay, for his benefit, we will have for acute liver failure and chronic liver failure. Acute liver failure, hyperacute, acute and subacute. Hyperacute is from 0 to 7 days. Acute is 7 days to 28 days or 1 month. And from 1 month to 3 months will be subacute. For chronic liver failure, it's more than 6 to 7 months of liver dysfunction. Yes, sir, you can go ahead. Sorry.
So extrahepatic manifestations can be pulmonary, can be renal.
Yeah, system-wise. You are
cardiac,
system-wise.
Cardiac, involving central nervous system and encephalopathy.
So can you elaborate a bit?
Yes,
cardiovascular.
Cardiovascular. Now, chronic liver failure leads to peripheral vasodilation.
Very good.
It results in high output cardiac state.
Okay.
It may also cause cardiomyopathy, which is missed because of the low peripheral resistance.
One word, hyperdynamic circulation. If you put one word, hyperdynamic circulation, that completes your answer. So they have decreased
potential with high cardiac.
Sorry?
Hypotension with high cardiac output.
Yes. So high cardiac output and decreased SVR mainly. And vasodilation, as you mentioned.
It may hide the cardiomyopathy.
Exactly.
Because apparently ejection fraction may look like fine.
Yes, coronary artery disease and cardiomyopathy may be hidden. We do not know because it of the hyperdynamic circulation. That completes. These are the 3 points which you should remember. So good. Next, respiratory, sir.
Sir, it may also cause bradycardia as high bilirubin levels are depress the SA node. So it may cause bradycardia also, sir.
Sure. Good point. This is also a good point. Yes.
More with the conjugated bilirubin, less likely than conjugated. Yeah. It causes significant shunting of the blood. Even up to 40% of the cardiac output may be shunted. This results in hypoxemia, which may be difficult to correct by giving oxygen.
So then
there may be pleural effusion or ascites because of the liver disease, which may further compromise respiratory functions.
Okay. And what about lung volumes? Or any decrease in the lung volume?
Yes, sir. Because of the abdominal distension,
FRC may reduce. Yes.
Maybe.
And it can have atelectasis, and as you mentioned,
volume is reduced.
Yeah, and pleural effusion. Can you elaborate about hepatopulmonary syndrome?
Yes, sir.
Yeah.
Hepatopulmonary
you
syndrome.
You told about this already, but in short, you told hypoxia. So this is elaboration of that. Yeah.
It's a syndrome characterized by hypoxia, platypnea, orthodeoxemia.
Can you elaborate those words, platypnea and orthodeoxia?
Platypnea is patient is comfortable lying flat, but gets dyspneic when gets upright, and patient's oxygen saturation is better maintained when the patient is lying supine, but when the patient is upright, oxygen levels fall.
Yeah. So what is the pathophysiology of this? So the pathophysiology is simple, sir. In any liver dysfunction, there is an abnormal increase in the nitric oxide. So there is a intrapulmonary vasodilation. It's a physiological. There is no extra vessels which grows, but the existing vessels in the basal lung gets dilated. So as you said, approximately 30 to 40% of the blood gets shunted through this abnormally dilated vessels and leads to shunt. So this leads to hypoxia. So when the patient lies down, there is an atelectasis and these vessels are compressed. And hence the shunt fraction is reduced and the patient feels better. So this is in short, the pathophysiology. And how will you confirm the diagnosis? Can you give me one test which is very important preoperatively? Usually it is done for those who go for liver transplant surgery. It is saline bubble test for your remembrance. So they give an agitated saline through the right heart.
It takes longer than 6 seconds.
Yeah, more than 6 cycles, 6 to 8
6
cardiac
cycles,
cycles.
6 cycles.
Yeah, then it is positive for hepatopulmonary. If it is in less than 1 to 2 cycles, then it is intracardiac shunt. Normally, there shouldn't be any saline seen in the left side of the heart, okay, because it gets filtered in the pulmonary vessels. So if you remember the saline bubble test, it is more than enough. So this is one important. Other than ECG, echo, resting echo, everything, they will expect you to tell about saline bubble test. Okay. The other component is portopulmonary hypertension.
It's the pulmonary hypertension followed pulmonary hypertension follows portal hypertension. It's because of the fibrosal change in age and in fact constitutes a contraindication to liver transplant.
Okay, correct. So it's an increase in the pulmonary arterial pressure based on the background of liver disease. So that is very important. So somebody has asked to elaborate about saline bubble. Saline bubble test is agitated saline, which is given through the right heart. Okay, and we look for the presence of this bubble, that agitated saline reaching the left side of the heart. Usually, in a normal patient, it should be filtered by the lung. If it is an intracardiac shunt, within 1 or 2 cycles, you will see the left-sided agitated saline reaching left side within 1 to 2 cycles. If it is a hepatopulmonary syndrome, 6 to 8 cycles, they will reach the left side of the heart. A brief account is enough. No need to worry about much in detail. Okay, sir. Anybody wants to take GI system? I think we will just shift between 2 or 3 people. Any GI changes? Dr. Minot, you want to talk?
There are portosystemic shunts which are formed in the GI system. So patient can present with esophageal varices, inorectal varices, then
Caput medusa.
Caput medusa.
Okay.
And
so GI, you should tell about portal hypertension, ascites, and splenomegaly. These are the 3 main things. If you add the spontaneous bacterial peritonitis, it's well and good.
Okay.
So portal hypertension and the pressure goes beyond 10 millimeters, or some books mention 12. So you can tell beyond 10 to 12 millimeters mercury, we call it as portal hypertension. So for anesthesia, it is very important because that can lead to increase in the aspiration risk. Okay, because presence of ascites can lead to decreased barrier pressure that can lead to increase in the aspiration risk. Next,
and so there may be another problem. Sometimes the varices may extend up in the esophagus, and inserting transesophageal echo probe or even RAS tube might cause hemorrhage.
Yeah, torrential bleed can lead to torrential bleed. So the renal, is there any 2 or 3 points about renal? Okay, for renal, it is mainly
hepatorenal
syndrome, and mostly it is pre-renal. 70% will be pre-renal because of relative hypovolemia. And a mention about secondary hyperaldosteronism should be there. I do not know, for reasons unknown, they are very fond about renin-angiotensin system. So they will insert this anywhere they want. And 2 places I got tested, and many other candidates who attended this on the same day got tested many times. So renin-angiotensin, you have to have it by heart, to my knowledge, because they, including what are the factors which initiates the renin-angiotensin system until the end, what is the effects of aldosterone and the ADH. They go very detailed. This one thing is renin-angiotensin, the Bohr's equation and cardiac output, shunt equation. They are very fond of asking this anywhere. So, and TIVA, basic principles of TIVA. So these are some, we cannot go to EDAIC without revising these. I think this is a very important thing. Then as Sir said, the CNS, hepatic encephalopathy, so that can lead to increase in the ammonia. Ammonia can lead to cerebral edema and intracranial hypertension. And
hematological effect.
Sorry, sir?
Hematological effect, decrease in
the clotting factors.
coagulation and disturbance of
coagulopathy.
coagulation factors.
Yes, anemia and decreased fibrinogen.
Fibrinogen, yes, sir.
And metabolically, hypoglycemia and hypoalbuminemia. Mention these two at least. If you can add more, well and good. At least these two must be mentioned, because this will be directly affecting anesthesia, both hypoglycemia and hypoalbuminemia. Okay, so these are the extra hepatic manifestation. So they will not ask you everything. They may ask you one or two system maximum. They may ask, give me the respiratory or GI or metabolic, one or two very specifically. So you should know that. Then how will you evaluate this patient and how will you optimize for it? Suppose this patient is coming for a laparoscopic cholecystectomy. It's an elective surgery. How will you evaluate this patient and optimize? He's a 45-year-old alcoholic with having a known chronic liver failure patient. His INR is 1.7. Albumin is 3.1. No ascites. He's got platelet count of 75,000, hemoglobin of 11. So how will you optimize this patient and take him up for the elective surgery? Anybody?
Yes, sir. So this is a alcoholic patient, and he's for laparoscopic cholecystectomy, and is for a major surgery, and his report shows that his proteins are less, and his you told about bilirubin also, sir?
Bilirubin I didn't mention. Bilirubin is 6. You can keep that 6, and protein 3.1, INR 1.7.
So he's posted for laparoscopic cholecystectomy. And this patient, I like to first go with a thorough history about the. I'll ask about the current problems, like what exactly is causing him for laparoscopic cholecystectomy, and then I'd like to know detail about his liver problem also, since detailed history as when he started, which symptoms he is getting, whether he has got any jaundice in the past, any history of ascites, history of tapping. So I'll try to gather all the information regarding his chronic liver disease. Then I'd like to, after getting all the detailed history, I'd like to examine this patient, since this patient is of chronic liver disease. So, and he's posted for a surgery. I'd like to examine his all the systems and see whether there are any systemic changes like RS, CVS, changes his effort tolerance, his abdominal examination, like for ascites, and then I'll like to know about his as I said, effort tolerance. And then after thorough examination, I'd like to check about his pallor, as they are also anemic. And then after thorough examination, I'd like to investigate this patient. And I'd like to, in investigation, I'd like to get his CBC done, complete blood count done, and specifically look for anemia and platelet count. And then I like to do is serum electrolyte, as they are also prone for electrolyte disturbance. Then I'll go for a liver function test and renal function test, specifically looking for a serum creatinine level in renal function test and BUL. And then his in liver function test, I'd like to know about serum bilirubin level. I'd like to know about ALL and SGOT and SGPT. And I'll be interested in his coagulation profile also. I'd like to know his PTINR status. And then apart from that, I'd like to get his CXR chest X-ray done and ECG done. And depending upon his hemodynamic status, I may like to know his oxygen saturation, and so that respiratory problems, chest X-ray, if there any involvement, and serum protein as well. So after thoroughly examining this patient, I'll like to stabilize this patient in one or the other form, like laparoscopic cholecystectomy, whether it is on the indication is emergency or elective. If I have got some time for stabilization as per the investigation and examination, I'd like to stabilize this patient before going for surgery. In stabilization, if I can.
Okay, sir. Coming to the patient, what we have in our example, how will you categorize this patient? Do you know any scoring systems to categorize this patient?
Yes, sir. In chronic liver disease patients, there is a Child's Pug score which is used. In that, there is 3 points, 1, 2, 3 points given for 5 parameters, in which first parameter is serum bilirubin level, which is 2, 2 to 3, and more than 3, 1, 2, 3 points are given. Then there is a serum albumin level below means less than
no
6.
No problem. At least if you can enumerate those 5, that should be enough. Means they don't go much into detail, but they may ask you to categorize this patient into which category. That you should be able to tell them. So INR of 1.7 and 3.1 albumin and 6 bilirubin, no ascites, no hepatitis.
So is as per the Child's Pug is in category 1. Score is 5 to 10.
Yeah, 5 to 6. Yeah, around 5 to 6. So it's a child
Pug score. It is category 1. Sir.
So what will be this perioperative mortality roughly? Morbidity mortality will be around 5%.
5%.
Yeah, if it is child Pug B, it will be 25%. Child Pug C will be approximately 50%.
50%.
Yes. So this you should know, because they ask for categorizing the patient on example. That you should be able to do that. Yes.
Yes, sir.
So suppose you said it is for a laparoscopic cholecystectomy. Suppose the same patient comes for a Whipple procedure for pancreatic cancer excision. Will your approach change, or is there any change in the thing? And before that, will you conduct that laparoscopic cholecystectomy as a daycare for a child Pug A?
For a child Pug A, sir, since he is a chronic liver disease and there are always chances of perioperative morbidity, I'll be a little resistance about conducting this as a daycare surgery, because I'd like to observe this patients at least overnight, as they can have a intra problem as well as post-operatively they can give problem, because their drug metabolism, everything is reduced. So I'd like to observe these patients, sir, for at least 24 hours.
Good. So it's up to you, no problem. So this question may come up and you can substantiate. So as you said, you want to go for post-operative liver dysfunction observation at least for a day because of the drugs which you have used. Or even if you say that I will discharge him and give him on follow-up, that's also okay. But whatever you say, substantiate what you are expecting.
Justified, yes.
Justified, that will be fine. And for this major elective surgery of Whipple's, is there any other which you have previously elaborated, like history, examination, and investigation? Is there anything which you want to add to your?
I'd like to, since this is a supra-major surgery, I'd like to prepare this patient rehabilitation, in which I'd like to prepare him system-wise, like respiratory system, I'd like to put him on a spirometry exercise. Then for proteins, I'd like to build up his protein structure so that, and if there are any electrolyte abnormalities, I'd like to correct them. If there are coagulation.
What electrolyte abnormality you are expecting? Is there anything which you want to specifically expecting any electrolyte abnormality?
In this patient, sir, I'd like to know calcium, serum magnesium and phosphate levels in this patient. And since chronic liver disease patients, and then I'd like to correct them preoperatively before taking
sodium
them
and potassium also. Sodium,
potassium. Yes, sir. Sodium, potassium.
Yeah. So they may be on either loop diuretics or spironolactone. So you should be potassium. Yeah.
Yes.
So any other thing like for Whipples you want to add? Preparation.
Cardiac evaluation of the patient.
Yes. Okay.
D-echo.
Okay.
Yes.
2D echo, or you can extend this to stress echo also. Abdominal stress echo is acceptable, and arranging appropriate blood products.
Blood and blood products.
Because these patients have got a lot of, at least if the child book B and C, they may have received multiple blood transfusion in the past, especially those patients who have got upper or lower GI bleed. So there could be a lot of allo antibodies. So arranging cross-matched blood product will take time by the blood bank. So make sure that you get adequate blood products, including PRC, FFP, and cryoprecipitate.
Yeah. Sir, any recommendation for using irradiated blood?
Irradiated blood, I don't think so. Is there any
only immunocompromised patients?
Oh, that's not a problem here, because there is a sensitization of the patient. Yeah, so they are more hyper immunologic. So that is a problem. They have got more antibodies. So that is the most important problem. And you can add about TEG. TEG can give you a current coagulation status of this patient who is going for a major surgery. TEG, you should know. Can you draw the TEG graph? Anybody?
Yes. Yes, I can, sir.
Yeah, please. So when you draw, try to keep drawing and explaining the parts of the graph so that you will save time. At least 20 to 30 seconds you can save.
So this is the TEG this thing, and this is initiation.
Okay, we could see that. Yeah, we could see your paper, sir.
Yeah, so this is the initiation phase and then clotting phase.
Yeah. Yes.
And then clot lysis phase. And this angles tells us whether there is a problem with the clotting or then the distance. And then if there is any problem with the anticoagulation as well. So it is a bedside modalities which can be done properly and gives us the proper information about current coagulation profile of the patients.
Okay, so TEG, you have to mention about R time, angle or K, then maximum amplitude.
Yes.
Yeah.
K value.
K value and alpha angle and the maximum amplitude, and lysis 30 and lysis 60.
Yes, sir. Maximum amplitude.
And lysis, correct.
Lysis 30, yes.
They may have some graphs on the computer, laptop, and they may show you some various types of TEG. They can ask you to interrupt. They can ask you to find the diagnosis. They can ask you to explain the thing on this one on their okay. Whether it is DIC or hypercoagulable, you should know all the various types of graphs so that it's easy for you. Suppose R time is increased, which blood product which you will suggest?
Fibrinogen.
Sorry, sir.
No. Let's say clotting.
Platelets.
FFP.
Yes. Platelets.
If this one alpha angle is increased, then you should, as you said, fibrinogen, that is cryo. For maximum amplitude, if it is less, you can use platelet. So FFP, cryo, and platelet. This is the sequence. Okay. So somebody had asked, what is the difference between TEG and ROTEM? TEG and ROTEM, the difference is the mechanism. That is, in TEG, the cuvette moves, but the pin rotates, isn't it? But in ROTEM, it is other way. Okay, and there's a subtle difference. It is based on the same principle of viscoelastic properties of the blood for coagulation, but there are some terminological differences between ROTEM and TEG. Even if you don't know, it's not a problem. TEG is something basic which they expect. Okay.
Yes,
Next. Okay, when this patient is coming for this either laparoscopic coli or Whipple's, will you pre-medicate? If at all pre-medication, which is your choice?
Sir, pre-medication will be obviously, I like to go for angiolysis, I like to go for antacids, and I like to go for a prokinetic, because these patients are having low esophagus, their chances of aspiration during the induction. So this will be my take for pre-medication.
Okay.
And then
so anxiolysis you don't mention, sir, because sedatives, they may be prolonged activity and that can lead to liver dysfunction. H2 antagonist is acceptable. This what you said is okay.
Benzodiazepines may precipitate hepatic encephalopathy.
Encephalopathy, so avoid that. As you said, aspiration prophylaxis is acceptable.
yes, sir.
And what will be a target INR or platelet or fibrinogen to take up this patient?
So at least the INR should be less than 1.7, and platelet should be more than 70,000 for this patient. Fibrinogen levels, I'm not aware, sir.
Around 100 milligram, 100 milligram per deciliter and above. If fibrinogen is less, you can give cryoprecipitate to reach more than 100 milligram. So
Yes.
these are some tidbits about the other points. And other investigations you can add for major surgery is ABG to look about lactate levels and how well the liver is functioning to metabolize lactate. That is another, lactate.
Yes.
And you can add up ultrasound. Anyhow, surgical team would have done an ultrasound. So you should know about the portal pressures, portal hypertension, presence of portal. This completes the preoperative evaluation for a major surgery. So what will be your goal of anesthesia in this patient?
Goal of anesthesia is, apart from preventing hypoxia, hypercapnia, it will be avoiding hypotension, protecting liver and kidney. So maintaining the good hydration will be the goal of anesthesia.
Use of shorter acting drugs.
Can I add, sir?
Yeah, please, sir. Go ahead, sir.
Would like to intubate the patient in semi-upright position, and would like to use intra-arterial BP monitoring with pulse contour analysis.
Hello. Sir, your voice is breaking.
Blood pressure can give me a okay. Can you hear me now?
Yeah, now we could hear better. Yeah.
Intubate in semi-upright position. Use intra-arterial BP monitoring with pulse contour analysis.
Okay, sir.
Restricted fluid therapy, early use of vasopressors.
Okay. So other than these, we can tell about maintenance of the blood pressure and hepatic blood flow and reducing the hepatic damage and decompensation. Okay. And use of, mostly these people will be very sensitive to hypotension. So maintain blood pressure and hemodynamics. As you mentioned, early use of vasopressor, and if need be, suppose if patient is having ascites pre-op, and how much ascites you will allow the surgical team to drain? Do you have any cutoff value?
I can't remember it right now.
5 liters. Should not drain more than 5 liters.
5 liters.
Yeah. If they drain more than 5 liters of ascites, you should replace the fluid with the help of albumin. At least 5% or 20% albumin. should be given. So these are some points we should remember for major surgery preparation. So now monitoring, sir has given some idea about invasive monitorings. So you'll have a low threshold for invasive monitoring for central venous pressure and intra-arterial blood pressure. And a word of caution about TEE, as already told, that it may lead to variceal bleed. So even a temperature probe should be inserted very carefully, and Rayleigh tube also should be inserted very carefully. These are some points which they will expect. And okay, choice. Suppose if this patient is coming for any other limb surgery, suppose he's coming for a fracture, or how will you decide about the choice of anesthesia? What will be a choice of anesthesia?
So first of all, I would see if the patient is able to lie down comfortably for the duration of the surgery. And if coagulation profile allows, a regional block would be preferred.
Okay. So regional block or a spinal also can be attempted. Epidural will be very dicey in some situation. In class B, class C, we cannot try epidural. Class C, at least epidural can be used. And tab block and other abdominal blocks
can be used.
Yeah, that can be given safely. That is not an issue. But epidural, spinal is okay, but epidural is importantly, we have to look about coagulation status. And hypotension following regional anesthesia should be promptly treated with either noradrenaline, sometimes the phenylephrine infusion.
Phenylephrine infusion.
Yeah. Other than noradrenaline.
And we may need to use higher doses of phenylephrine. Because cardiovascular system may not be so responsive.
And the use of even terlipressin they have used to maintain hemodynamics, because it leads to splanchnic vasoconstriction. So that is also a good choice of vasopressor. So advantages and disadvantages of regional and GA. So general anesthesia advantages. Anybody wants to tell? See, these patients will have a lot of VQ mismatch, as we saw in the hepatoportal or pleural effusion. So it optimizes these VQ mismatches with our positive pressure ventilation. It gives more hemodynamic stability. We can restrict our usage of drugs. Disadvantages is aspiration risk, and a lot of airway manipulation can lead to bleeding, and polypharmacy can lead to drug-induced hepatic failure. So these are few disadvantages. At least 2 or 3 in each side you should be able to tell. Regional anesthesia advantages, we can maintain. Yeah, hypotension can be treated easily, and you can minimal invasive and reducing polypharmacy. And it improves post-operative analgesia and comfort to the patient. These are the advantages, and reduces the aspiration risk. But disadvantages is any regional can lead to hematoma, and that should be decided on depending on the patient coagulation status. Okay. So this is some words about this one. Next, what will be your induction agent of choice? Neuromuscular blocking agent, and which opioid will you use?
Obviously, as patient is of liver problem, having a metabolism problem, and there is also a change in volume of distribution. So I'd like to select the short-acting drugs, in which I'd like to go for a propofol and fentanyl or remifentanil opioid. And as far as neuromuscular blocking drugs is concerned, I'd like to go for atracurium in this patient, so that I can have a proper monitoring, and the metabolism is by the hydrolysis in the blood itself. If it comes to volatile anesthetic, I'd like to go for a sevoflurane or desflurane in this patient.
Opioid, which opioid? You said already fentanyl.
Fentanyl or remifentanil.
Remifentanil. Okay. Morphine. Any trouble with morphine usage?
Sir, there is a metabolism of the morphine which is will be disturbed, and the metabolite itself can accumulate in this patient, leading to prolonged action, and also the
morphine.
Histamine.
Yeah, correct. You're right. Metabolism. Yeah, and morphine fixed needs renal excretion. Sometimes,
renal excretion.
Yeah, hepatorenal syndrome can accumulate morphine. And the metabolite of fentanyl is non-active, so you can safely use fentanyl. Yeah. Yeah, propofol can be safely used, and the infusion also is allowed because you have extra hepatic metabolism of propofol. So that is another point which you can mention here. Neuromuscular blocking agents, as you said, organ-independent metabolism of cis-atracurium and atracurium is the best choice. Succinylcholine, any
Not
word
to
of
be used, sir. Not to be used, sir.
not to be used? Okay, why?
There may be low levels of pseudocholinesterase. It may cause
Prolonged action. So prolonged action is possible and pseudocholinesterase. And
considering the benefit of
so for rapid sequence, rocuronium can be used. For rapid sequence induction, rocuronium
can be used, and you will use the neuromuscular monitoring to
monitoring by
QoF. Yeah. So this is about pharmacology. Induction dose, is there any change in the loading dose in these patients?
Yes, sir. Loading dose is usually increased.
Increase volume.
But top-ups are less frequent and less reduced.
Increase volume of distribution.
Volume of distribution, yes. But this is offset by the decrease in the plasma proteins and albumin, so which will increase the free fraction. So clinically, there is no big difference. So you ultimately reduce the doses. Okay. So how will you maintain anesthesia in such patients?
So maintaining the anesthesia will be my target. Will be hemodynamic stability, and as I said, short-acting drugs will be preferred in this patient, so that will not have a long effect. And I'd like to maintain them with inhalational oxygen, air, and sevoflurane combination with if it's a major surgery like a Whipple, I'd also like to go for a combination of tab block along with the general anesthesia, so that my requirement of general anesthesia will go down.
Yeah. Yes, and you will also maintain. You can also maintain. This is one type of maintenance where you are depending on volatile. Other acceptable mode is propofol with remifentanil infusion also. Target. Yeah. Okay.
Target infusion.
Yes. Yeah. And other intraoperative goals of you should avoid hypothermia, acidosis, hypocalcemia, and maintain blood glucose because they are more prone to hypoglycemia.
Okay.
Yeah.
Hypoglycemia.
Yeah. And what are the choice of fluids, sir? Fluid management?
So I'll go for
albumin or balance salt solution.
And
avoiding lactate.
Yeah. So we try to avoid starch-based colloids because that can lead to increased incidence of renal replacement therapy. Yeah. So we will avoid that. And as you said, the balanced salt solution, albumin infusion, and early use of blood products are very common, but that should be judicially used. And because this is not free of problems. So reducing the incidence of blood transfusion and early use of vasopressors like norepinephrine and phenylephrine. So these are general management. Post-op care. So what, suppose the patient after Whipples, what will be your post-op care goals?
Since this is a major supramajor surgery which goes on for a long time, so my post-op care will be obviously I'll like to send the patient in high dependence unit, and with a continuation of the thorough monitoring of all the systems in the post-op. And I'll specifically like to check for the ventilatory efforts. If my threshold for going for a elective ventilation till the correction of temperature or outcome from the neuromuscular blocking drug is, if I'm doubt, I'll go for a elective ventilation till the patient is completely out of it. And otherwise, I like to, if their situation demands, I may go for a CPAP or oxygen support, 100% oxygen by the nasal this thing. Then apart from oxygenation, my aim will be maintenance of warm temperature control and pain management and DVT prophylaxis will be my another important factor in the post-op management.
Yeah, DVT prophylaxis is very challenging actually. This patient will be hypercoagulable or hypocoagulable.
Hypocoagulable.
So you can mention that At least it is
I'd like
challenging. Yeah, you should.
Yeah,
be.
I'd like to go for at least mechanical,
Stockings or
like
pneumatic
the pump
compression.
stockinets, and I'd like to take care of analgesic by multimodal therapy, in which I like to use the combination of paracetamol and local block or opioid in low doses, so that they will
You
not.
can mention PCA of fentanyl, no problem, because PCA fentanyl is very safe. And NSAID
Yes.
should be avoided because that can lead to platelet problem and to GI bleed. Paracetamol, you can reduce the dose. Instead of QID, we can go to TDS dose. Yes, that is acceptable. Any other thing specifically for this patient in a major surgery? Add lactulose, because you have to give laxatives to reduce the incidence of hepatic encephalopathy. And maintenance of fluid and hemodynamics to reduce, to maintain normal urine output. And in case it's a major surgery, continue broad spectrum antibiotics to reduce sepsis, like tazobactam, piperacillin tazobactam can be used. So these are about the post-op care. So we will complete the session with a word about acute liver failure. This acute liver failure, this will come in your ICU table. The most important is acetaminophen toxicity. So general principles of management, they will expect you to tell about ABC, because initially the patient may be comatose. Okay, they may have a hypothermic. Yeah. So ABC, you should start with your ABC and maintain intubate, because intubation is never a crime. So you tell intubation because the patient is comatose. I don't want to make sure for two reasons: to avoid aspiration and to maintain normal carbon dioxide, so that there is no hepatic, cerebral disturbance, and maintain a normal carbon dioxide levels and oxygenation. So to maintain that, I will intubate. Then I will give a lot of fluids to maintain circulation and start vasopressors earlier. Then if it is acetaminophen, then you can talk about N-acetylcysteine.
N-acetylcysteine.
Dose is not important. At least you should know the mechanism of action. That is, it's a glutathione
regeneration. Yes.
Yeah.
So
that basis, that basis is important. And you should always add antibiotic to avoid sepsis or multi-organ failure. And a word about King College criteria, which you should know specifically for
liver transplant.
Yeah, they will ask even they will ask you to enumerate this criteria. So pH,
it's either pH less than 7.2, or then other three factors.
Either
like
pH is less than 7.3.
Yeah, serum creatinine more than 3.6, 3.5. Then
thrombin time less than more than 100
seconds or 6 INR. And then grade 3 or grade 4 encephalopathy.
Yeah. So this patient, if it means if the patient proves this criteria, then he should be shifted to a center where liver transplant is a possibility. Yeah, transplant should be. Somebody has asked which criteria. This is King College criteria for liver transplant and acute acetaminophen poisoning. So please go through it. So this is very important. So that's it. So this
activated charcoal therapy
for if it is less than 4 hours. Less than 4 hours, you will give the charcoal. Hello.
Sir, I've read about acid prophylaxis using ranitidine in many of the books.
Yes.
Why not PPIs?
PPIs because the ranitidine gives reduced gastric volume. That's what they say. That's why they go for ranitidine. PPIs, I do not know. You can tell PPI, it shouldn't be a problem because we are using it regularly. Shouldn't be a problem. Okay, so these are the 3 or 4 contexts where your liver patients may come. One is a minor or a major elective surgery, emergency surgery, acute acetaminophen toxicity, or basics of liver. So these are the 4 components, which if you finish, this will be a short pass question for you. Okay.
Thank you, sir.
Okay. All the best. Bye-bye.
Thank you, sir.
Thank you.
Thank you.